everyone, and welcome back to the Chronic Corner. I'm Lauren, and this episode is all about the top prescription meds and drugs used to treat dysautonomia and POTS. Now, we could just list off a bunch of drugs for everybody and kind of see what we recommend, but instead we want it to be as authentic and accurate as possible. So we actually put together a couple little clips from our speaker series last year with some top dysautonomia and POTS specialists. This way you can hear it directly from them.
Medications, keep in mind there is no level 1 or even level 2A evidence regarding medications. However, there is consistency in observations. For example, there are a lot of patients with avebradine and COVID POTS. So we see that, but no one has done good double-blind studies with all the good and bad. But midodrine can be used. In our small population that we have, we gradually up-titrate the dose. Many times you just give one dose, like 5 milligrams 3 times. I find in my small population that up-titrating is a good idea. My students or others can look into it, but my general feeling is we don't end up using 5 milligrams 3 times. Many patients require a higher and lower dose. So maybe generic is not a good idea, but as I already told you, this is a personal observation. Droxidopa I've used in POTS. In the study that we presented, they were like 50%. 13 patients with difficult POTS, 6 benefited. Cafergot is my personal observation too. I've used it in very complicated cases with great success. But these medications should only be given by people who know how to watch it and follow it. So just don't go out and ask for a prescription. Pyridostigmine, also known as Mestinon, in our experience, the syrup works better than tablet. However, the published data actually will be more it doesn't matter. Again, my students can do a research on that. But I think in the things that we haven't published, but we have looked at, syrup worked better at a lower dose. And DDAVP, people do use, Florinef, people do use, avebradine or Corlenor. And we actually reported on it when Corlenor came out, and that's only our studies. But we started with a very low dose of 2.5, and we gradually up-titrated it as opposed to the therapeutic dose of 5 milligram. And long story short of it is that I think you end up using a lower dose. In the study that we did, the median dose, that is the most common dose, was 2.5 twice a day versus the minimum dose of 5 milligram. That is, and it's of course an off-label use. Beta blockers, the message to take home is all beta blockers are not created equal. Some work better than others. Again, as I mentioned, there are no double-blind studies, but there are several case series that will say one beta blocker is better than the other. And they have been studied also. Prozac, I've used it a couple of times. I have a patient overseas, actually from Japan. She actually takes Prozac for POTS and it works. And there is data on that. And personal observation on digoxin, since the recent trial came out on digoxin and it is back in favor. Sometimes I add digoxin to Corlenor. Again, it's a personal observation. Should not be considered standard of care, but it worked around 50% of times on top of Corlenor, not alone.
Medications that I like to use are beta blockers at a low dose, not just to reduce the heart rate, but also to reduce general sympathetic overactivity and symptoms that can be caused by that, such as anxiety, physical anxiety, insomnia, tremors, this internal vibration feeling that a lot of long haulers talk about. We have Florinef, we have midodrine, Mestinon, we have Ivabradine or Corlenor for patients who do not tolerate beta blockers well, or have contraindications to beta blockers. I use it then. Antihistamines, tricyclics, which are medications at low dose. They are for neuropathic pain and headache. Gabapentin is our neuropathic pain medication. I use stimulants like Adderall or Ritalin or Vyvanse for patients with fatigue and brain fog. SSRIs can certainly be used, especially if there is significant anxiety or depression. I also use low-dose naltrexone in selected patients. But I need to mention something, is that many times long haulers come to me and they put themselves on a bunch of vitamins and they want all of these medications, including low-dose naltrexone, because they've read somewhere on the internet that these are good medications. So it's very important to understand these medications are going to be chosen based on your individual symptomatology. And so an individualized approach is best, not just kind of, well, these are good, because everyone is different and everyone's symptoms and presentation will be unique to them.
So let's talk about drugs if we're going to get there. And we'll touch on a few of these quickly, and then we'll stop. So IV saline has gotten a lot of attention. I will say that acutely it works, right? So this is old data. It's almost 25 years old now. And what it shows is that an hour after receiving IV saline, if you look at the far right, the heart rate went from meeting the excessive orthostatic tachycardia criteria, it looks like it's about 33 beats a minute, down to an increase of about 15 or 16 beats per minute, which is normal, right? So acutely, it altered the physiology and improved things. Just doing the tilt, afterwards, shown on the left with placebo, does not make that difference. What I'll say is that I do use this. So if someone is decompensating and they end up in emerge and we're trying to figure out whether to admit the patient or not, my advice is usually to try and get the doctors to give the patient a liter or two of saline and see how the patient feels then. Because I think a lot of patients will feel better. The acute increase in blood volume often is enough that the patient is able to go home. The problematic area is when it comes to chronic use. And the problem is how to get the saline in, right? And you need to get an intravenous catheter. You need an intravenous catheter for that. And if that's done once in a while, that's fine. But every time you access the vein, you actually clot off a little bit of the vein. And so if you keep doing this, access becomes a big problem. It becomes very hard to get an IV in the future. And then there's a slippery slope that often leads to getting a PICC line and then eventually a portocatheter central line. And most professional guidelines recommend against that because of the access issues, because central lines have their own risks, and some of which are life-threatening risks. There are a couple of series that have been looked at on the use of IV saline chronically in POTS patients. One in a pediatric group out of Washington, which reported a much higher rate of complications actually than in other groups that had chronic lines, right? So if they compared to oncology patients that had chronic catheters, there was a much higher rate of line complications in this group. But there's a group out of the Toledo group actually published a case series where patients actually did fairly well without too many complications. But it's worth noting that the majority were on it for a short enough period of time that they never went to a central line. So I guess what I'd say about the IV saline is that if it's really only being used as a bridge, for a very short bridge, not a long bridge, like a short bridge across the driveway, not like, the Golden Gate Bridge, right? It may be reasonable, but there's a very strong danger of slippery slope because people do feel better with the IV saline, right? And it sort of lures you in, but then you're left in this difficult situation where you're sometimes left having to either give it up or feel a lot worse because you've almost in some ways become dependent on that approach. DDAVP is desmopressin. It's a drug it's on the market, I think, well, for different things. But one of them is to help 5-year-old boys who wet their bed, right? It encourages free water retention. You stop peeing. We've shown that with water does acutely lower heart rate. And we've tended to use it as a special event drug. So you want to go to a movie on Thursday night with friends, well, you don't know how you're going to feel. If you take this in the afternoon, chances are your blood volume is going to be expanded and people do feel better, right, for several hours. I rarely use it every day, but there is some data, I'm not sure if it's published, but mainly out of Toledo where they were giving 0.2 milligrams nightly. Why I'm hesitant to use it more is that while it's safe enough that we give to 5-year-old boys, we don't tell 5-year-old boys to drink 3 liters of water. And retaining free water and a drug that prevents you from getting rid of it runs the risk of diluting out sodium and other electrolytes in your body, and that can actually be life-threatening as well. So if you're taking DDAVP, you must get your potassium checked frequently with your doctor, or sorry, not your potassium, your sodium checked frequently, because hyponatremia, the first manifestation can be neurologic and severe, right? So you want to pick that up before it's a problem. Very important with DDAVP that while little may be good, more is not better, right? More can be life-threatening. Let's talk about some other agents. So mitidrin decreases orthostatic tachycardia as well. This is from the same paper from 25 years ago. You'll recall that the saline, knocked the orthostatic tachycardia in half. The mitidrin took the edge off, right? So mitidrin does have some benefits. It's not in the same league as saline, but there is some data that it helps. Beta blockers, there are people that are believers and people that aren't. I'm in the big pro beta blocker camp. On the one hand, you have a lot of heart rate. Lowering it as a cardiologist is something we were always trained to do. However, a lot of patients that came to us at Vanderbilt reported being intolerant to beta blockers. And there's some data from Julian Stewart with esmolol that it didn't actually make people feel better. But when we studied at Vanderbilt, we used 20 milligrams of short-acting or regular-acting propranolol. It was great, right? It lowered standing heart rate. It lowered the orthostatic tachycardia. Importantly, it lowered symptoms. And quite frankly, it was the winner for most patients. It was the one that most patients responded best to in terms of symptoms. But it turns out there's a dose dependence to this, right? So I think the reason why a lot of patients don't tolerate beta blockers is that they go and see a cardiologist, and the cardiologist dose the patient the way they would a patient after a heart attack. And that's with full dose beta blockade. And what we found is that as we went to fuller doses of propranolol, while the heart rate and blood pressure were lowered, the symptom improved away. So the symptoms started to get worse again. So the approach with propranolol is not to fix the heart rate, but to take the edge off the heart rate. So just a little bit of propranolol and more is not better. Ivabradine is a drug that's been on the market for about 5 years, I think, in the States, mainly for heart failure. There have been case series suggesting benefit in POTS patients, but it wasn't until earlier this year, and Pam Taub's group from University of California in San Diego published a randomized trial in POTS patients with high standing norepinephrine levels, so potentially hyperadrenergic POTS patients, showing that the ivabradine did improve symptoms. Right, so I think it was 5 to 7.5 milligrams twice a day. So there is some data for ivabradine now. My understanding in the States is that insurance coverage is still often difficult for patients with ivabradine. So this may be in theory a better treatment than in practice in terms of being able to get the drug, but there is data supporting its use. Acetylcholinesterase inhibition with pyridostigmine, it's a peripheral acetylcholinesterase inhibitor. So what that does is it increases the amount of acetylcholine that lingers because you're preventing or slowing down the breakdown. And we've shown that it does lower heart rate in POTS patients, and it improves symptoms acutely in our hospital-based setting. The truth is it's a pretty smart drug. It helps a little. It's not great. It's not potent by itself. Often I use it in combination with beta blockers. Importantly, Blair Grubb's group published a large case series in 300 patients where over half reported symptom improvement with it, but about 20% had to stop the drug due to intolerance, and almost all of it was due to abdominal cramping and diarrhea. So if you're prone to diarrhea, I don't use it. But if you're prone to constipation, the side effect may be great because it increases gut motility, so it may actually be helpful. And the final thing I'll say is about norepinephrine transport inhibition. So typically these are drugs that are in the serotonin norepinephrine reuptake inhibitor class, or SNRI drugs. We use atomoxetine, which is an ADHD drug, but there are a bunch of drugs in this class. And this is the only drug that we use in our studies at Vanderbilt that actually worsened tachycardia and made symptoms worse, right? And that's because the norepinephrine which is what we expected actually, because the norepinephrine transporter is a sympathetic synapse clearance transporter. And so if you inhibit the norepinephrine transporter, you end up with effectively more sympathetic tone, right? So you saw that slide earlier where we're trying to decrease sympathetic tone by increasing volume. This does the opposite. So again, not everyone got worse. About 2/3 got worse, and 1/3 either had no change in symptoms or or felt slightly better with it, but it's unlike any other drug that we studied. So we recommend patients stay away from SNRI drugs if at all possible.
So those are the main ones that our top physicians that we spoke with would recommend. If you've had any luck with a specific prescription for your POTS or dysautonomia symptoms, we would love to hear from you in the comments below. Please keep in mind, if you are reading the comments and looking for suggestions, that everyone's body is different. Just because a drug worked for one person, it may not work for you, and it's always important to be open and honest with your physician before, during, and after taking any kind of prescription med. And for more things, visit DINET.org. Thank you so much for watching.